This patient was clinically dead for 47 minutes. No pulse, no breathing. Conventional CPR failed completely, but they walked out of the hospital 3 weeks later. How is that even possible? The answer is a machine that most people have never heard of, but it's literally rewriting the rules of life and death in hospitals around the world. And what I'm about to show you is going to completely change how you think about what's possible in modern medicine. Alright, you guys, welcome back to another video lesson from Nurse Brain. My name is Neil Brian Galve, and if you're new here, this is where we take the most complex critical care topics and break them down so you can actually understand and use this knowledge to save lives. Now, I need to warn you up front. What we're covering today isn't your typical medical equipment review. We're talking about ECMO, extracorporeal membrane oxygenation, and this technology is so advanced, so powerful, and it's literally the difference between impossible and possible in critical care. But here's what's going to shock you, and this is something that even experienced ICU staff often don't fully grasp. ECMO isn't just another tool in our toolkit. When we put someone on ECMO, we're essentially replacing their heart and lungs with a machine. We're taking over the most fundamental processes of human life. And here's the part that's going to blow your mind. We can do this while the patient is awake, talking, and fully conscious. Imagine having a conversation with someone whose blood is being oxygenated by a machine sitting next to their bed instead of their own lungs. By the end of this video, you guys, you're going to understand not just how this incredible technology works, but when it can save a life, when it can't, and why the decisions we make around ECMO are literally life and death choices that happen in minutes, not hours. Let me start with a statistics that's going to stop you in your tracks. According to the Extracorporeal Life Support Organization, there have been over 185,000 ECMO runs reported worldwide. That's 185,000 times that every other form of life support failed, and ECMO was the only thing standing between a patient and death. But here's what's really going to change your perspective, and this is something that most healthcare workers don't realize until they see it firsthand. ECMO has a dirty little secret. It doesn't actually cure anything. I know that sounds crazy. We're talking about this incredible life-saving technology, and I'm telling you, it doesn't cure anything. But stay with me, because understanding this concept is absolutely critical. ECMO is not a treatment. ECMO is time. It's buying time while we fix whatever is killing the patient. It's like having a pause button on death itself while the medical team works to address the underlying problem. Think about it this way. If someone has severe pneumonia that's destroyed their lungs, ECMO can take over the job of oxygenation in their blood while treat the infection. If someone's heart is failing after a massive heart attack, ECMO can maintain circulation while we try to restore heart function or prepare them for a transplant. But here's the crucial part that separates successful ECMO programs from unsuccessful ones. The underlying condition has to be either reversible, or we have to be using ECMO as a bridge to something definitive like a transplant or a ventricular assist device. And this is where the life and death decisions come in, because putting someone on ECMO who doesn't meet these criteria isn't heroic medicine. It's prolonging suffering. Now, let's dive into how this incredible technology actually works, because understanding the mechanics is going to help you understand when and why we use it. At its core, ECMO is brilliantly simple. We're going to drain blood from the patient's body, run it through an artificial lung outside their body, and oxygen, remove carbon dioxide, and pump it back into them. But the devil is in the details. First, you've got to cannulas. These are large plastic tubes, much bigger than regular IV catheters. We're talking 23 to 25 French for drainage cannulas. To put that in perspective, a regular IV is usually 18 to 20 gauge. These cannulas are massive because we need to move a lot of blood very quickly. Next is the pump. Modern ECMO circuits use centrifugal pumps. Imagine a spinning cone that creates pressure to move blood forward. But here's what's fascinating. Unlike your heart, which can adjust its output based on what your body needs, these pumps are dependent on both preload and afterload. If the patient becomes dehydrated, flow drops. If their blood pressure spikes, flow drops. This is why ECMO patients need constant intensive monitoring. Then we have the oxygenator. This is where the magic happens. Modern oxygenators use thousands of hollow fiber membranes made of polymethylpentene. Think of it like thousands of tiny straws where oxygen flows on the inside and blood flows on the outside. Gas exchange happens across these membranes, just like in your lungs, but actually more efficiently. Now, here's where it gets really interesting. Because there are two completely different ways to set up ECMO, and the choice between them determines whether we're supporting just the lungs or taking over the entire cardiovascular system. VV ECMO, that's veno-venous, is our respiratory support. We drain blood from a vein, oxygenate it, and return it to another vein. The patient's heart is still doing all the work of pumping blood around the body. This is what we use for severe respiratory failure, COVID, ARDS, severe pneumonia, massive pulmonary embolism. The lungs are shut, but the heart is strong enough to maintain circulation. But VA ECMO, veno-arterial, this is where things get intense. Now we're not just supporting the lungs, we're completely bypassing both the heart and the lungs. We drain from a vein but return to an artery, taking over the entire job of circulation. This is for cardiogenic shock, massive heart attacks, or cardiac arrest, when conventional CPR fails. And here's something that's going to blow your mind. We can actually initiate ECMO while doing CPR. It's called ECPR, extracorporeal CPR. Picture this. Someone's in cardiac arrest. We're doing chest compressions, and simultaneously, we're connecting them to a machine that's going to take over the entire cardiovascular system. The 2023 American Heart Association guidelines now recognize ECPR as a reasonable intervention for selected patients, but only if we can establish flow within 60 minutes of arrest. Now, we get to the part that separates good critical care from great critical care, knowing when to use ECMO and, just as importantly, when not to use it. The respiratory failure, we're looking at specific numbers. APF ratio, less than 100. That's when you know conventional mechanical ventilation isn't going to cut it. But it's not just about the numbers. We need to see that this is a potential reversible process, or that we're buying time for a long transplant. For cardiac support, we're talking about patients who need 2 or more inotropes and still can't maintain adequate circulation, or patients in refractory cardiac arrest where we can get ECMO established quickly. But here's what's absolutely critical. Timing is everything. For cardiac arrest patients, every minute without adequate circulation is brain cells dying. We need to get ECMO flow established within 60 minutes of arrest. Recent studies show that each 12-hour delay in initiating VA ECMO increases mortality by 6%. And here's the part that's difficult but essential. Sometimes the answer is no. Unwitnessed cardiac arrest, prolonged CPR without adequate perfusion, disseminated malignancy, severe multi-organ failure that can't be reversed. These are situations where ECMO isn't going to help. But here's what's changed recently, and this is important. Some things we used to think were absolutely contraindications aren't anymore. Severe obesity used to be a no-go, but recent systematic reviews show survival rates comparable to non-obese patients. Advanced age isn't an absolute contraindication, but frailty Specialty is becoming one. ECMO decisions can be made by one person. It requires a multidisciplinary team: surgeons, intensivists, ECMO specialists, sometimes ethicists, and these decisions often have to be made in minutes, not hours. I've seen families have to make the decision about ECMO for their loved one while that person is actively dying in front of them. It's one of the most intense situations in all of medicine. Now, let's talk about what happens when someone is on ECMO, because this is where the real complexity begins. First challenge: blood doesn't like being outside the body. The moment blood hits that artificial surface, it wants to clot. So every ECMO patient needs anticoagulation, usually with heparin. But here's the impossible balance. You need enough anticoagulation to prevent the circuit from clotting and killing the patient, but not so much that they bleed to death. We monitor this with ACT levels, anti-factor XA levels, sometimes thromboelastography. The target ACT is usually 180 to 220 seconds, and bleeding is the most common complication. It happens in about 30% of patients. When you're anticoagulated and you have large cannulas in major blood vessels, bleeding becomes a constant threat. But the anticoagulation is just at the beginning. ECMO changes everything about normal physiology. Drug pharmacokinetics are completely altered because of the large volume of the circuit and the drug absorption by the tubing. Medications that normally work predictably suddenly don't. Kidney function often deteriorates. About 60% of ECMO patients need dialysis. And here's something fascinating. We can actually integrate dialysis into the ECMO circuit. So one machine is replacing the function of the heart, lungs, and kidneys simultaneously. And then there's the brain. Stroke occurs in about 7% of VV ECMO patients, and even higher rates in VA ECMO. These aren't small strokes. We're talking about potentially devastating neurologic injuries that can completely change someone's life even if they survive. But here's what's remarkable. Many ECMO patients are awake and alert. They can talk, interact with family, some can even walk around with assistance. There's something surreal about having a normal conversation with someone whose blood is being oxygenated by a machine outside their body. Recent studies show that with bicaval dual lumen cannulas, up to 60% of VV ECMO patients can be mobilized out of bed. Imagine walking down the hospital hallway while connected to a machine that's keeping you alive. For families, ECMO represents both ultimate hope and ultimate terror. Hope because their loved one is alive when they shouldn't be. Terror because they're watching their family member connected to a machine that's literally keeping them alive moment by moment. The average ECMO run lasts 3 to 4 days, but some patients are on for weeks. Imagine visiting your loved one every day, knowing that if that machine stops working, they die immediately. Let's talk numbers, because this is where hope meets reality. For VV ECMO and ARDS, we're seeing survival rates around 60 to 67%. For COVID-related ARDS, it's been 48 to 60% in experienced centers. Those might not sound amazing until you realize these are patients who had essentially zero chance of survival without ECMO. For VA ECMO, in cardiac arrest or cardiogenic shock, survival rates are lower, around 20 to 30%. But again, these are patients who were dying despite everything else we could do. But here's the reality check. ECMO is expensive. The average cost is over $200,000 per case. A single oxygenator costs thousands of dollars and might need to be changed multiple times during a run. And it requires massive resources. Successful ECMO programs need 24/7 on-site coverage, specialized teams, and aim for 1:1 specialist to patient ratio during the first 24 hours. This isn't something you can do halfway. But when it works, it's miraculous. I've seen patients walk out of the hospital after being on ECMO for weeks. I've seen heart transplant recipients who were kept alive on ECMO until a donor heart became available. I've seen young parents go home to their children after being clinically dead. But I've also seen families struggles with the decision to withdraw ECMO when it becomes clear that the underlying condition isn't reversible. These are some of the most difficult conversations in all of medicine, explaining that the machine keeping their loved one alive isn't actually helping them get better. ECMO technology is advancing rapidly, and what's keeping next is going to change everything. We're seeing smaller, more portable devices, magnetic levitation pumps that cause less blood trauma, better biocompatibility, surfaces that requires less anticoagulation. Some centers are even experimenting with ambulatory ECMO, patients going home while still connected to the machine. The indications are expanding too. We're using ECMO for high-risk procedures as a bridge to recovery in drug overdoses, even for severe hypothermia. The 2023 PRONECMO trial showed that prone positioning during VV ECMO is safe and feasible. But here's what doesn't change and never will: the need for healthcare providers who understand this technology. Whether you're a nurse, respiratory therapist, physician, or any other member of the healthcare team, understanding ECMO makes you a better clinician. You might be the person who recognizes that conventional therapy isn't working and suggests ECMO. You might be providing bedside care to an ECMO patient and catch a complication early. You might be the one explaining to a family what this machine does and why their loved one needs it. Here's what's concerning. Despite ECMO being available in over 1,200 centers worldwide, many healthcare providers still don't understand it. They see the machine, they know it's important, but they don't understand when it's appropriate, how it works, or what complications to watch for. That knowledge gap can be the difference between life and death. ECMO represents the absolute pinnacle of what we can achieve in critical care medicine. It's the technology that lets us look death in the eye and say, "Not today." It's the bridge between impossible and possible, but it's only as powerful as the people who understand it, use it wisely, and provide the intensive care these patients require. If this deep dive into ECMO has opened your eyes to what's possible in modern critical care, smash that like button. It helps get this crucial information to more healthcare providers who need to understand this technology. And if you haven't already, subscribe and hit that notification bell, because next week we're diving into something equally mind-blowing: the future of artificial organs and how bioengineering is creating solutions we never thought possible. Drop a comment and let me know, have you ever cared for an ECMO patient? What was that experience like? I read every single comment and love hearing your stories from the front lines. Remember, in critical care, knowledge isn't just power. It's the difference between giving up and finding a way. It's the difference between saying there's nothing more we can do and saying let's try ECMO. Thanks for watching, and I'll see you in the next lesson where we continue pushing the boundaries of what's possible in critical care. Once again, this is Nurse Brain, inspiring greatness one lesson at a time.